Traumatic Brain Injury by Tawwab Ansari, Kira Miller, and Kendra Wines. Objectives. Student nurses will understand the pathophysiology and causes of traumatic brain injury by the end of this presentation. Student nurses will be able to list the appropriate diagnostics and complications related to traumatic brain injuries by the end of this presentation. Student nurses will be introduced to the clinical manifestations of traumatic brain injuries by the end of this presentation. Student nurses will understand the proper nursing implications and interventions for traumatic brain injury by the end of this presentation. Pathophysiology. Traumatic brain injury occurs as the result of an external force upon the head, which causes a wide range of functional changes that affect thinking, sensation, language, memory, and emotions. The first stages of cerebral injury after TBI are characterized by direct tissue damage and impaired regulation of CSF and metabolism. This ischemia-like pattern leads to accumulation of lactic acid due to anaerobic glycolysis, increased membrane permeability, and consecutive edema formation. The second stage of the pathophysiological cascade is characterized by terminal membrane depolarization, along with excessive release of excitatory neurotransmitters. Can be classified as open or closed traumatic brain injury. Open occurs when skull is fractured or when it is pierced by penetrating objects. Closed, integrity of skull is not compromised. Causes. Blunt force trauma. Head injury occurs when the head is struck or strikes an object, resulting in concussion or contusion, also classified as closed injury. Penetrating trauma. The skull is fractured or pierced by an object being exposed to environmental contaminants, also classified as open injury. Classifications. Primary brain injury occurs at the time of impact and results in axonal shearing and associated areas of hemorrhage. Secondary brain injury occurs from insult to the brain after the initial injury. This includes hypoxia, hypovolemia, and cerebral edema. It is categorized into 3 different categories. Mild GCS, Glasgow Coma Scale, of 13 to 15 is a mild traumatic brain injury. A moderate traumatic brain injury is a Glasgow Coma Scale of 9 to 12. A severe Glasgow Coma Scale is 8 or less. Glasgow Coma Scale is broken down into 3 different categories: eye response, verbal response, and motor response.
Intracranial pressure monitoring. Normal ICP goes from 10 to 15. Treatment usually begins when ICP is more than 20. Positioning, you want to keep the head of the bed at least 30 degrees neutral or midline. Basic setup includes catheter, external transducer, and collection device for CSF. Catheter placed in burr hole of lateral ventricle and connected to drainage system and transducer. Transducer leveled at the external landmark and zeroed. Atmospheric pressure. Transducer sense pressure of CSF. Some complications of traumatic brain injury is immediate seizures, hydrocephalus or post-traumatic ventricular enlargement, CSF leaks, infection, vascular injuries, cranial nerve injuries, pain, bed sores, and multi-organ system failure. Some assessment expected findings you would find with traumatic brain injury. You want to always assess the patient's airway first. This is our priorities following our ABCs. Neurological assessment, you want to assess the patient for amnesia before or after the injury. You want to assess their Glasgow-Coma Scale score. You also want to assess their loss of consciousness and the length of time the patient may have been unconscious. Assess for CSF leakage from nose and or ears. You want to test for the halo sign. This may be indicative of a basilar skull fracture. Increased intracranial pressure assessment. You want to assess for manifestations of increased ICP. This can include severe headache, nausea, vomiting, deteriorating level of consciousness, dilated or pinpoint non-reactive pupils, cranial nerve dysfunction, alteration in breathing pattern, deterioration in motor functioning, or abnormal posturing. This can include decorticate and decerebrate posturing. Cushing's triad. Cushing's triad is bradycardia, widened pulse pressure, and hypertension, and seizures. Some interventions for patients who have had a traumatic brain injury is, as we said before, airway management is our priority here. We also want to monitor and reassess that neurological status. We can use the Glasgow-Coma Scale or another term of assessment. You want to have patent intravenous access, prevention of secondary brain injuries, and you want to monitor and manage the patient's ICP and CPP. So you can also elevate the head of the bed by 30 degrees. You want to give fluid management with hypertonic solutions, and you want to monitor and control their blood pressure. Limited hyperventilation, temperature control, drainage of CSF, and our surgical treatment, seizure precautions, and some pharmacological interventions are going to include osmotic diuretics such as mannitol, glucocorticoids, sedatives, antipyretics, anticonvulsants, and narcotics. Some labs and diagnostics. Some lab tests you're going to want to do is your ABG, or arterial blood gases, CBC with differential, blood glucose level, blood and urine osmolarity, toxicology screening, and you want to monitor anti-seizure medication levels. Some diagnostic procedures. You want to do cervical spine films to diagnose cervical spine injury if it's present, CT scan of the head and neck, MRI may be done of the head and neck, and you want to also measure that cerebral perfusion pressure using the ICP monitor. Discharge teaching for a patient who had a traumatic brain injury. You want to encourage this patient to receive adequate rest. Also teach them to avoid strenuous activities. This includes heavy lifting, bending, standing, and to avoid alcoholic beverages. Teach the patient to avoid driving or operating heavy machinery. Let the patient know that they may have mild headaches, nausea, and difficulty in concentrating once they get home. The patient should follow up with their primary doctor as soon as possible. You may want to refer a patient and family to appropriate resources. A good resource is the Brain Injury Association of America. If brain death occurred, you want to give the family information and support on organ donation.
NCLEX question number 1. A client has a traumatic brain injury and is mechanically ventilated. Which technique does the nurse use to prevent increasing intracranial pressure? A. Assessing for Grace Turner sign. B. Maintaining neutral head position. C. Placing the client in Trendelenburg position. D. Sectioning the client frequently. The answer is maintaining neutral head position. To prevent ICP in a client with traumatic brain injury who is being mechanically ventilated, the nurse needs to maintain the patient's head in a neutral position. Maintaining the head in a neutral alignment prevents obstruction of blood flow and is an important component of ICP. NCLEX question number 2. The nurse is evaluating the collaborative care of a client with traumatic brain injury. What is the most important goal for this client? A. Achieving the highest level of functioning. B. Increasing cerebral perfusion. C. Preventing further injury. D. Preventing skin breakdown. Answer to this question is A. Achieving the highest level of functioning. The most important nurse's goal for the client with TBI is to help him or her achieve the highest level of functioning possible. NCLEX question number 3. A nurse in the critical care unit is completing an admission assessment for a client who has a gunshot wound to the head. Which of the following assessment findings are indicative of increased intracranial pressure? Select all that applies. A. Headache. B. Dilated pupils. C. Tachycardia, D. Decorticate posturing, E. Hypotension. The answer is A, B, D. Headache, dilated pupils, and decorticate posturing are all signs of increasing intracranial pressure. Additional signs of ICP includes bradycardia and hypertension, also known as part of Cushing's triad. And that's all. Thanks for your attention.